Yeah, Monday Grand Rounds. Just before I welcome our guest speaker this morning, I would like to remind everyone that next Monday morning at this time we have the annual Howard Virtual Lecture, which is a special, we invite a special speaker, and this year it's Dr. Anne Marie Valente from Boston who will be speaking to us. So I encourage you all to join us next week, and I will now turn it over to my friend and colleague Ash Tamini for the Grand Rounds. Thank you.
Quick announcement before I turn it over to Dr. Good morning, everybody. I just want you to be introduced to, we have a new team member, a new education specialist. This is Maya Hendel-Patterson, and I will be bringing her around, but you'll be hearing from her more in coming days. Thank you. Welcome.
All right.
Oh, I'm sorry.
Oh, there you go. He's here.
I am so sorry. It's been just a little hectic this morning, so I guess I'm a little disheveled. So here's Dr. Nickelbein to talk about Cascade FH.
So if I asked you to name a disease entity that was twice as common as hypertrophic cardiomyopathy, but caused more morbidity and mortality, had a 50% untreated morbidity mortality rate by the age of 50, would you be able to name it? And that's familial hypercholesterolemia, and that's why we partnered with about 25 sites in the United States to enroll people into this registry. The name of the registry is Cascade FH Registry, and Cascade screening, meaning it's an autosomal dominant entity, and our aim is to identify sentinel cases, get them properly diagnosed and treated, and then identify their either siblings, parents, or children. We've enrolled, we're one of the top enrollers, and we're only at the 115, 120 mark, which really points out the poor diagnosis of this entity in the United States. We looked at our own data here at Alina and looked at 1 million ambulatory records in Alina, and we found about 1,200 people that may have this disease. We found a proper diagnosis rate of 4%. So we're asking for people to begin to look for these and identify these individuals in their practice. These individuals develop not just cardiovascular disease, so not just stroke and heart attack, but they also develop aortic stenosis. They have accelerated atherosclerosis and leaflet degeneration. And once they get registered, we will properly diagnose and treat. It's fairly easy to diagnose. If you have an LDL of greater than 190 and you're above the age of 20, there's an 80 to 85% likelihood that you have this entity. So those are the kind of people we'd like to see. Genetic testing is definitive but expensive and controversial. We do a clinical-based diagnosis, either Simon Broom or MedPed criteria. So if you want to diagnose it yourself and refer to Christine, the manager on the project, or myself, or send to one of our clinics, and we will go ahead and do that. So that's the registry.
All right. Thank you, everybody, for coming to today's Grand Round. It is my pleasure to introduce Dr. Moses Wananu, who is presenting today under the topic Cardiovascular Disease Trends in the Developing Countries, especially in Sub-Saharan Africa. He needs no introduction. Dr. Wananu is a second-year cardiology fellow of ours here through Hennepin and Abbott. He did his internal medicine residency at Danbury Hospital, Connecticut, and where he served also as a chief resident there. And prior to that, he did medical school training at Ross University in the Dominican Republic. As you know, Dr. Wananu and I share kind of a common geographic background. Both of us are from East Africa. I'm from Kenya. I'm from Ethiopia. He's originally from Ethiopia. I'm sure this has not escaped everyone's mind recently that both countries and similar countries in the region have been referred to as the cradle of mankind, owing to the numerous fossils discovered there of early hominids. I was not going to say anything else. Without further ado, I will invite Dr. Wananu to to the stage. Thank you.
Introducing another presentation the system didn't like.
There we go.
There we go.
Hey, can you hear me okay? So thanks everyone for coming. Once I knew I was going to present today, I was torn between doing case presentation, which I did at Hennepin, versus just giving an overall background. And I think the thing that became more important for me is kind of giving an overall picture on what's going on in a lot of developing countries right now, because a lot of people that I've talked to, they're still thinking about, infectious diseases and things like that. But there have been a significant trend even within the countries themselves, and we're largely unprepared for what's going on. So the objectives of the talk, I'll be talking about the disease trends, patterns, treatments, and I'll highlight a few of the limitations we have. I'll touch base on a couple risk factors, and then proposed way forward. And then I'll talk about a small personal project that I did and have been doing. I've been going back to Kenya almost every year since 2011. I started as a medical student with a team of doctors and people working the OR. And then the take-home points. So as it is, it was really hard to even start finding out where can I get the last, 50, 60 years of information. And mostly this is just meta-analysis from 27 studies that compiled about 86,000 medical admissions from 1950 to 2010. Diseases were reported according to ICD, and mostly they were categorized into infectious and parasitic, respiratory, circulatory, where we have cardiovascular diseases, digestive, genitourinary, and others. And the first slide here shows from the 1950s here. I'd just like to bring your attention to the circulatory here, which is this bar here, where it was much slower. And then, as you can see, as the decades have been going, the percentage has been increasing. Infectious and parasitic diseases were the leading cause overall, almost 20%, and respiratory illness were second, circulatory third. But the biggest thing from that graph is this, that the proportion of admission due to circulatory almost increased 5 times during the same time period. Infectious and parasitic diseases decreased, but at some point there was a higher increase, which I'll mention next in this slide when we're looking at mortality. And the biggest thing you can see from the infectious disease here is that there was a big jump in the 1990s here. And we can guess why that is, and now it's a lot less. But the main thing for that is probably HIV at that time. And World Health Organization has been projecting that by 2020, which is a few years away, but I think more so like by 2030, Sub-Saharan Africa and other developing countries have seen a major, major shift where there's a dramatic drop of death and overall comorbidities, mostly from infectious diseases, and this rise in non-communicable diseases. So if you look at the WHO top 10 leading causes of death globally, this was in 2000, where you can see the ischemic here. accounting for about 6.8 million, and stroke 5.4. Then when you go to 2015, that number is higher to 8.7, and stroke is 6.24, accounting for almost slightly over half of all deaths that we're seeing. And then if I break it down to high income, medium income, and low income, in fact, the word now is stepping away. I think in 2016, WHO stepped away from developing countries and things like that, because if you look at high income countries, there's some which are high income, but they're still developing countries. And the way they figure high income countries is you just take the gross national income per capita, and they just divide it in 1,000. There's some minor numbers like 1,045, but generally it's just 1,000 and less per capita. That's low income country. Then 12,000 and above, that's a high income country. So you have this broad range of middle income countries, and that's what I would like to tease out. Because for the high income countries, we all know the number one cause is ischemic heart disease. If we go to the low income countries, the lower respiratory infections that are leading. That is 1,000 and less. But if we look at the medium income countries, here they're kind of lumped summed together, where you see ischemic heart disease and stroke and cerebrovascular disease are pretty close. But if you tease this out, where you go to the upper middle income, because I think 1,000 to 12,000 is such a broad range of just grouping everybody together. But here they've divided it where 1,000 to 4,000, that's the lower middle income countries, and then from 4,000 to 12,000, that's the higher middle income countries. So for the higher or upper middle income countries, ischemic heart disease and stroke are very close. This is the 4,000 to 12,000. Then if you go to the lower middle income countries, the 1,000 to 4,000, where a lot of the countries in developing countries are getting into this category, there is a silent person who's been creeping in slowly, where you see ischemic heart disease is by far taking over, especially in the urban areas. And this has largely been ignored. So let's talk about the 4 stages of epidemiologic transition. And as you would expect in earlier years, where the stage 1 is of pestilence and famine, life expectancy being low, the dominant causes of cardiovascular diseases, it's really infectious, and in that being rheumatic heart disease, and then nutritional deficiencies like beriberi and the rest. Then you go to receding pandemics, where people live to about 50 years. Still infectious diseases and stroke are predominant. When we go to stage 3, where you have a lot of the low-income countries and the low middle, where now you're finding longer life expectancy, ischemic heart disease starts showing up. And for the rest, high-income countries you already know. Alongside this slide, I would also like to point about the stages of health and nutritional and demographic changes. I think these slides, I'll just summarize it quickly here for you. It shows both the demographic, epidemiologic, and nutritional transition as countries are going from low-income countries to the middle to high-income countries. And at some point, they all start getting to this area where there's reduced fertility and people living longer. By that, people not having as many children, that's the meaning of the reduced fertility they're pointing out there. And then you have chronic diseases that start to emerge a lot. And then as nutrition, people would eat, there's receding famine, and then there's nutritional related non-communicable diseases that start predominating because of, high sugars and things like that. And the emphasis at that point is trying to focus on medical intervention, policy initiatives, and behavioral changes, which is what the United States and other high-income countries are doing to curtail the non-communicable diseases. If you look at the trends over the decades, there's two things I would like to point your attention to. The first one here is the cross over time from 1990 to 2010, where you find the non-communicable diseases here have been steadily rising, and the communicable diseases have been declining in percentages here. And on this slide, on the high-income countries, death related to non-communicable diseases, by the way, non-communicable diseases are things like, cardiovascular disease. I'll share that coming up slide with you. The high-income countries, there have not been a lot of increase. Actually, there is a dip towards a decline over time because of all the three areas people have been attacking: nutritional changes, policy initiatives, and interventions. But every other income countries, there's just been a steady rise in them. So here are the non-communicable diseases. So you have cardiovascular disease, diabetes, cancers, and chronic respiratory illnesses like COPD. But of this, there's 4 major modifiable risk factors that account for almost 80% of these diseases, being tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. This just shows the path slowly that leads to the chronic non-communicable diseases. There are about 4 factors. You have environmental, and on environmental, I would like to highlight the urbanization and globalization. McDonald's, I don't think it's in Kenya yet, but there's Burger King and all these other, big fast food places that are spreading there. Behavioral risk is where you have tobacco use and healthy diet, and then biological risks, high blood pressure, high glucose, obesity, and then leading to this. So early versus late intervention impact. And this really is the crux of my talk, because we're still in the early stages where we are seeing this major shift and rise. Obesity is not as high to 33%. It's still around, in the 20% in most of these developing countries, in the mid-20s. And you can see that, you cannot change much of your genetic predisposition. But if interventions are started at this point, perhaps over the life course of a population, there can be a major reduction. But if there is so much delay and all the resources are being put to other things, by the time people are realizing, okay, we need a lot of interventions on things like that, yes, it can be done, but the impact of that intervention is not as much as if things can be done earlier on in the pathway. So what are the patterns here? Unfortunately, most of these studies are only obtained from very few places. You can see East Africa, Kenya, there's Ethiopia, Sudan. Egypt is doing a lot more publications as well, and South Africa, and then West Africa. And look at that. There's really positive data. This is one of a few that I saw, but the highlight of this is just to show you the age and gender distribution of acute myocardial infarction that is seen, with majority of the people being, from 60 and 50s. But really, looking at the studies, it actually shows people get myocardial infarction much younger than people do in high-income countries. This tried to summarize the age between 6 different countries: England, Ethiopia 55, you can see Senegal. Most of these are in the 50s, and then the others about 60s. This was an attempt to see of all the people who were admitted in a hospital with different diagnoses, how many of them actually had MI, and try to get an estimate of prevalence of MI. And you can see the total subjects were pretty high, but this raises questions about how is MI really diagnosed, to find like 0.1 and 0.4, and then in Sudan where they found 10%. And the main difference in all this is the fact that in one of these here, it was really autopsies that they did, and really found coronary artery disease was much more than expected. But most of these other ones, it was from EKG and CKMB. That is predominantly what they were using to diagnose that somebody has myocardial infarction. And this is a table of mortality, but I'll skip over to talk more about the death attributable to coronary artery disease or cardiovascular disease. And the main point of this is just showing the projection from 2000 to 2030, that in the United States, most people ages 35 to 64, most should be on this higher end. You find that in these developing countries or middle income countries, a lot of the people who will be having cardiovascular disease related mortality are much younger in this population compared to the United States. Presentation is the same. I was just curious to see how are most of this presenting with myocardial infarction. But the interesting thing I saw was the fainting aspect. I think some of them, it's so delayed, and after they get it, by the time they're brought in, they're in VT or they're suffering from arrhythmias by the time they're coming to the hospital. And there's nothing much to do when they get there. And the diagnosis, like I alluded to earlier, mostly is this ST deviation and CKMB. Troponin is not widely used. In some places they're using them. And then angiography is done in 8.3 and echo in about 5% of the people. Treatments and limitations, all patients given oxygen, sublingual nitroglycerin on the way, aspirin, beta blockers. I thought this was curious, getting ACE inhibitors within 6 hours. I couldn't find a clear guideline or directive as to why a lot of people are getting ACE inhibitors, but it's not widely, but some places it's just a practice that they put on ACE inhibitors within 6 hours. And for STEMI, a lot of them are started on thrombolytics or heparin treatment, but it's not so much of activation of cath lab or anything like that. And 35% no improvement on this regimen. 20% offered to be taken for angiography, if no improvement. And there's a lot of discussion. One of the saddest discussion you find is somebody who is almost, on the verge of death, and you're talking about money before being taken, to get your intervention. Do you have money? How are you going to pay for it? And somebody is writhing in a lot of pain. And it's really a big challenge seeing that. And then 10% of the ones who undergo angiography are referred for CABG within the country or abroad. And a lot of them go abroad or to private hospitals within the country. So limitations or some of the things that you find from that is only 50% or so recover, and completely is just, it's not completely, but relatively better than the rest. 44% develop cardiac failure, and 5% of them die, but I think this is even underestimated. The major limitation that we keep seeing when we go there is resources. Very, very limited resources that we see. No clear guidelines on how to approach a patient who is coming suspicious of AMI. I know talking with Dr. Tamini, and it's really hard. There's no, I'm yet to find places where somebody is coming and, there's somebody on call. You can say, let's activate the cath lab, take them. It's clear STEMI, but most of them in the meantime will get thrombolytics, and maybe this will be done the next day. And then the other major limitation, sorry if this is hazy, I tried to see how much publication is actually being done so that you can bring impact. Guidelines and things like that come from publications themselves. And these numbers are the dark areas. They had to figure out, over 5 publications a year related to cardiovascular diseases. And then these other shaded areas here, it's about 1 to 5 studies per year. Yes, there's an increase in the amount of studies being done, but for the most part, you can see there was not a lot that's being done. And out of interest to see what is really being published for the ones who are doing the publications. You can see from the Medline Index, of the total of about 1783 publications from 95 to 2004. Most of them focused on HIV, malaria, parasitic diseases, and cancer when you go to the non-communicable diseases. But for cardiovascular disease, it's still, the percentages are quite low. And a lot of these studies are coming, from South Africa. There's, to my knowledge, maybe somebody else knows, I haven't seen a lot of prospective studies. There's one for heart failure that they did for about 5 years, just to see if the people they followed them for 5 years, what were the main causes of heart failure and being hypertension. But otherwise, we don't have anything like Framingham or something like that. Risk factors. The main risk factors we all know, but the Interheart Africa study tried to categorize them, but they all share similar risk factors that we know, with an addition of infectious disease, that's one of the risk factors. Oops, I think I went fast. And then low fruit vegetable diet accounted for one of the other risk factors. But the one alarming thing for people interested in, endocrine is diabetes. And this is a projection to 2030. And the dark colors just shows you from 2010 to 2030, the percentage of increase of diabetes, which also I think is accounting and driving what would be the cardiovascular diseases. And it's just really, really alarming if you see that. And most of this that are going to be affected are countries that don't have the resources to tackle the non-communicable diseases. So I looked at my own country, the prevalence of metabolic syndrome. And Lydia Kaduka is the one who did a sample of study where it looked at the urban, most of this was done in Nairobi. And 32% of the population now living in the urban areas have metabolic syndrome. The prevalence is higher in women, and some of it is because of the social aspects, where, for women, if you have a higher BMI, it's seen, it's more admirable than a lower BMI. It's socially acceptable. And for men, especially the ones with money or higher income, the first thing is if you're making more money and you look skinny, they think you're still very, very broke. You need to add a few more pounds. I know when I went back home the first time from here, and I think when I came in, I'd gained almost 40 pounds in undergrad, just eating a ton of burgers and things like that. And my grandmother thought I was pretty wealthy, and I was just in undergrad. But really, the social aspect of things have started to change. This was the perceived notion where, telling people, you really need to have good BMIs. It's mostly educational right now. And as you can see, comparing obesity and overweight people in rural versus urban, it's almost double or close to triple. I kind of talked about the social aspect of that. The impact of this overall, and this is what one of the other things that is really concerning to me, is that most of the people who are being affected is people in their 50s and 60s. Therefore, somebody works so hard, they get a good job, and then the next thing they start living really bad, unhealthy lifestyles. And then they end up getting non-communicable diseases early on, and they're the ones who are also impacted with morbidity and mortality. So what's the way forward? My proposed thought of this is, I know it's a busy slide, but it cannot be tackled by one or two things. There's some people who go and do a few procedures and then, you come back, but the impact has to be really from 3 different aspects. And if you look at the individual here, family, neighborhood, these are the people who are representing the main community. Most of what I've been talking about is just the determinants here, but the things we're trying to do in these countries is from the policy approaches to the health communications. And in the health communications, some unique ways that are being used. I know recently in the ACC they talked about, the hypertension with barbers and who helped reduce it. But I know it was funny, but it really caught my attention that when they went to the barber shops and talked to the people there, for some reason, they relate better to people. Somebody can listen to the barber shop or somebody better than even they can listen to their physician, because they would relate to how they're talking to them. So one of the ways that I've seen with health communication with HIV that really helped drop significantly in some of the East African countries is that the celebrities took on the onus on them to spread the information about HIV. And in a lot of concerts, before the concerts would start, they would talk about prevention to the people who were there, and then made some songs about HIV and prevention. And now there is a lot of move towards telling people about cancers, especially breast cancers and stomach cancers from, smoked preservatives that people use. So I think that's one way that's being used, apart from the healthcare providers that are doing it because they don't seem to reach their population as well. And then the other way is through preventative and diagnostic. This is where partnering with countries or teaching hospitals abroad can also help facilitate to bring in policies and guidelines that can help curb this disease. So let me step away from that. That's the overall view. So I'll just share a quick personal project that I did. And this was, I started in 2011, where the first time we went there, and I had a question in mind. I was just curious, how many people, or how has treatments been in the past where people go and provide treatments and things like that? What was the basis as to which people go? We went to the 5 major hospitals in Kenya, and the biggest hindrance that I saw is that people were very suspicious. Some cardiologists say there's a hostile takeover because people come here, they say, we're going to use your cath labs, we're going to use, your operating rooms, bring all your kids who are sick, we'll treat them, and then afterwards you do, 20, 30 procedures, everybody pats themselves on their back, very excited. Went to Africa, we saw kids, we did cleft lip and all this stuff. And then afterwards, when they leave, no major impact. The people who are there don't even know how to do what has just been done. So really brief, and I know it's still good because there's some kids who've been helped, but the impact of that is very, very small. And when I went for that trip, the question was like, what are the major things that are hindrances? And one of them was cost, which is hard to deal with, because for the people we had about 28 patients who had coronary disease and did about 100 charts to see. And for the week we were there, about three patients had valve disease that were fixed, but 1 cabbage, and the rest had PCI. But the question I had was, what if the cost is reduced? Because most of the people cannot afford it. So as far as cost, the government has taken a big initiative, insurance. The insurance is covering a lot. I just went there in December, and we're doing pacemakers, and they were fully covered by the insurance. It was not an issue at all because up to half of the population is covered. But with the policy being covered and the cost coming down, I think there's better ways that partnering with people who are going for these trips can bring greater impact. So the challenge we had is that this was the largest hospital in Kenya, Kenyatta National Hospital, has about 1,800 beds, but any given date has 4,000 to 5,000 patients, some on the floor and things like that, which is not uncommon. And then the cost of cabbage is about 7,000, and average annual household income is 7,000. PCI, about 2,000 to 3,600, and mostly in the private hospital. And this was the biggest thing that I didn't know. Was when I was there and they said, okay, yes, we'll do a procedure and things like that. I said, well, the patient has to buy it. They don't, I don't even know, because I was like, how does the even patient know which kind of valve they want to have, or the procedure that they need to do? But so they just told it's how much, and mostly it's donated stuff. So I think the bureaucracy of this, where you have things that are donated to be given and then the patient has to buy, was some of the barriers that were a little unsettling to me. But thankfully, like I wrote here, this has shifted. The last time I was, in December, I was talking to the people there and asked them, are people still getting some of, a lot of the expired stuff? And the government has stepped in and said, number one, if it has been donated, it cannot be charged, but also they're starting to refuse the expired stuff, because now with insurance kicking in, as long as somebody is working and they contribute about $5 to $10 a month, a lot of the places can have insurance cover them. But let's talk about the actual other challenges for people who are supposed to be doing the procedure. The morbidity is pretty high, about 15%. But one of the things is this, that kind of caught me by surprise. You have multi-specialized surgeons. The one day we were there, we did, open heart surgery with one of the chief of the hospital, and then he told the cardiologist, so the surgeon, are you going to come in tomorrow? We have another procedure. Oh, he was very excited. What are we going to be doing? He said, we're doing renal transplant tomorrow. And it's the same person who will be doing renal transplant, and then same person who will be doing pediatric cardiology was flying to another place. So this is not uncommon to find that. And I don't think it's purely by choice. It's just by demand. Because as they were training, rotating in different places, some of them were exposed to pediatric. And therefore, here you have a situation where a child is going to die, and there's nobody else who is trained enough to do it, so they end up doing it. And then the number of cardiologists in the country is few. Maybe Abbott has about half the country, or close to 3/4 of you find in some countries, and even more. And then there's also medical tourism that is significant. And then poor follow-up afterwards. You try starting somebody on Coumadin. When you are there, you see somebody with large atrium, starting them on Coumadin, and coming there with American mentality. You should follow up every 2 weeks, or initially, and then follow up after a while. And the person looked at me and said, no, you started, you see them once, and then you see them in 2 months, and hope that everything is working well. But these areas are also being addressed, because you find that they're opening just clinics for that. And this is the one I talked about earlier. So I was going to show a video. Let's see. So this is during open heart surgery. You can see it there, huh? All right. I think because it's not embedded, you can't see, but I'll just describe it. It was during a time open heart surgery was going on, and the lights went out. And it was a tense 1 minute where everybody just holds up and you wait, and then the light came back up. And everybody else was really freaked out, and except the people used to doing this, they say, just wait for a little bit, lights comes back on, and you continue. So these are practical things as well that you see in some of the places. So some of the accomplishment, I would like to highlight, is when the cost was brought down with insurance kicking in, a lot of people can actually afford to be treated. And then when the hospital saw this, they actually built a cath lab, and it's operational right now. And other public hospitals building cath labs. The private hospitals have had cath labs for a while, although it was much more expensive for the general public to reach. So that's what I pretty much summarized there. PCI is roughly around 175, with the rest being covered by insurance. And I think the collaboration that has been existent is exciting. And one other thing that I would just like to point out, we're currently involved, I think as of 2 weeks ago, we just got the Ministry of Health in Kenya, they had all this data. They have so many data that they're sitting on, but they didn't have a lot of people who could do any analytics on it or anything like that. But one of a friend of mine who was trained here went back home, was given by the Ministry of Education about 4,000 patients with diabetes. It's raw data and has to be cleaned up. And the thought is, What if we do our longitudinal study on it and just keep them for the next 20 years? And the easiest follow-up there is through cell phones, because as opposed to other countries, especially in East Africa, with your cell phone, you have everything. It's like a bank. I don't need my credit card anymore, even cash, when I go back home. You just go eat, there's a till number, you pay with your phone, done. The employer just then pays you, goes directly to your phone. And everybody, therefore, a phone number is so critical. You know, my mother's had the same phone number for almost 20 years. They won't let go because it's their bank. It's their bank number. And therefore, with enrolling patients and using their cell phone number, that's the identifier, and you're most likely going to follow them for the next, 20 years. They lose their phone, they just call the phone company, they shut down usage of that number, but the person who has a cell phone number, as soon as they get another cell phone, they continue with their number. So that's one of the ways we think it might be successful, because the cell phone number is really your identity. So what are the take-home points here? There's rapidly increasing cardiovascular risk factors as a result of behavioral and epidemiologic transition that has occurred, and largely unprepared. And in some districts right now, cardiovascular disease deaths are the leading cause. And the risk factors are similar as are seen in high-income countries, with the exception of infectious disease, which is also a risk factor. And one of the ways I can think it's similar to here is how, people should get vaccination against influenza. I guess it's the inflammatory state where probably it might reduce myocardial infarctions. And there's an urgent need to prepare and focus resources to address what's expected to be the leading cause of death by 2030 in sub-Saharan countries. More quality studies need to be done, especially quality and impact studies, to just see how they'll impact the population. And I think for the people who are interested to go abroad, the adage that they should have is, teaching a fisherman how to fish, where the whole thing from the surgeon to the sonographer to the perfusionist, they work alongside, right from diagnosing the patient before, during the procedure, and then even at follow-up clinic, so that there's better ways to show how decisions are made. That's it. Thank you.
Questions? No questions?
Well, that was a great talk. Thanks, Moses. One thing I'm wondering about is, on a population basis, what do you see as being necessary to reduce the burden of, let's say, smoking or hypertension, these being kind of the easiest things upstream to attack? Is there much work being done on a public health basis?
Yeah, I'll go back to, the involving of what has been the most impactful, apart from medications, because in my first trip when I went there, I took a quick sample of the patients that we were seeing, and I wanted to see, of the ones who have heart failure, how many of them are on the guideline-directed medical therapy. So initially in 2011, it was, if I were to give you a percentage, it would be less than 30%. And then over the years, it's a question that I'm always interested in. Whenever I go back, I ask that. And as of last year, when I went there, I saw the people that were being seen, all of them were on guideline-directed medical therapy, at least 75 or 80% of them. But the problem was they were not on the appropriate doses. But at least there was a move where people, there's education. But I think the bigger impact that can be done is using of people like the celebrities and people like that, where through those, the information is much more widespread, because it's so hard to convince people who don't feel the symptoms of the hypertension. I remember one of my uncles, when he came here and he went to the emergency department, had a slight headache, and not emergency department, see a primary care physician for follow-up, and his blood pressure was in the 260. And therefore, right away, it was told, no, you have to be admitted, and it was a fight. So then there's no way you're admitting me. I walked here. Why shouldn't I be taken emergency to the ED? So there's that huge knowledge gap of these underlying diseases that people are not aware of, and just the social aspect of. But headways are being made, but mostly through the media. Media is friendly.
Great talk, Moses. So I would like, kind of more of a comment than a question.
Yeah.
So my personal experience, Sub-Saharan Africa is so diverse. There's so many countries. It would be kind of very difficult to put everything together and give a blanket statement. So, some of the things that you mentioned that you do in Kenya, I don't think that we do them in Ethiopia currently, like the cell phone way of, banking and things like that, or insurance for that matter. So, a number of things have changed. At least non-communicable diseases are going to be, a lot more important in this part of the world, primarily because, number one, the population is really, increasing. The fertility rate is high compared to the rest of the world. Number two, we have started to live longer. The life expectancy, when I left the country, that was in 2005, has gone up from about 47 years on average to 65 years, largely because of reduction in infant mortality, yeah, and largely because of treatment of HIV/AIDS. Yeah. So, as time goes on, this cancer, cardiovascular disease, and all that, they are going to become more important. But we really are not at a spot or poised to kind of tackle those, almost expected significant problems that we're going to face at this point. And this is kind of a multifaceted situation. Everybody knows that. I don't need really to say much about it. It involves political commitment. It involves money, economic growth. It involves population education, being aware of what is important and things like that. So with regards to at least what to do to treat the low-hanging fruit, like let's say managing hypertension, smoking prevention, and the likes, I think we can take some lessons from the HIV/AIDS pandemic. At least when I left the country, HIV/AIDS was at its peak. The prevalence rate, at least in Ethiopia, was close to 15%, and people really were not getting any treatment for it because they could not afford and because there were very limited resources available. And what changed was the government really became committed, and then through multiple means, whether it is through the use of celebrities, through population level education, your next of kin, your friend at school, your teacher, whether it is by the roadside, or whether it is at the at the water spring where you fetch water with the with your community friends and all that. Everybody got involved to a point of teaching how to do safe sex, what the risks are involved with HIV, and what are the treatments, what to do when you have these symptoms and all that. So it became a population-based education, and then the treatments came in. So this was primarily possible because of the funding that the region received through USAID and through the Bill Gates Foundation. That is the biggest thing that changed it. So for me, if we are going to do or change, what we're going to do about this kind of situation is, funding has to come from internally or from globally, whether it is through the WHO, the World Health Organization, or through foundations like that. So currently in Ethiopia, I'll tell you, when I was training in medicine, an acute MI case was, kind of a ground level case. We rarely saw it. Most of the cases I treated are either severe cases of malaria during the malaria seasons. I've seen so many types of malaria, so many types of complicated TB, but we rarely saw, MI or stroke. Yeah, we saw them, but there were very few. Currently, there have been new changes like cath labs being set up. These were not the case back when I was training. We still don't have the emergent cath lab activations, and all that we do here for STEMIs, usually it is based on lytics. The thing that also kind of concerns me, and also it is kind of gut-wrenching, is when you're present with any acute situation, it could be an accident, it could be any illness, is you really have to come in with a bag of money. And the hospital would first charge you for the amount that they would assume that you're going to stay, for example, like a set level of 50,000 local currency. Unless you bring that money, you are as good as dead. So the overall outlook of how to deliver healthcare, that is also quite different. I hope things would change, but I'm not sure. There are changes, but I'm not at a rate that you'd want them to change at. But anyways, thank you for sharing. I don't have a lot of questions.
We do have another question. Hang on.
Thank you, Moses. I'm just wondering, with the data that you showed about the age of the patients with the cardiovascular disease being somewhat young, is there any evidence of an intersection between that occurrence and HIV? In other words, is the HIV treatment in some way interacting with the increased incidence of coronary artery disease, presumed coronary artery disease, in this, outside of other risk factors like smoking and hypertension?
Yeah, and that's a possibility. I'm not sure, but I would tend to think so, because if you look at one of the risk factors there that emerge, other than the other risk factors that are common, is infectious disease being, it was a signal that it's important as a risk factor there. So whether it's the inflammatory aspect of it versus the treatment of HIV per se that, increases lipids as well, and I'm not sure, but I would think that it's a possibility, it's an interaction.
Any other questions? Okay, thank you, everybody. There are flyers out there for the virtual lecture next week. If you'd like to pick one up, and please stop by and thank Janssen, both Chuck Stark and Denise Burt and Allie Moon with Otsuka for sponsoring our session today. Thank you.